Hey guys, welcome back to Job Studies with Fun. My name is Angad and we are here for Pediatrics Part 6. So let's start guys with first of all emergencies in pediatric respiratory disorders. Well, whenever we talk about pediatric emergencies guys, always remember it is going to be A, B, C, D, E. Now the important part over here is they'll ask you what is the short full form of this thing. Remember A for airway, B for breathing, C for circulation. Now this was a PYQ which they asked. D stands for disability and E stands for exposure. Okay, this also they might ask. So make sure that you know the full forms. All right. So let's start with our first question, guys. An 11-month-old infant who was apparently well and playing 30 minutes back, now all of a sudden had developed sudden onset of difficulty in breathing. So this is, remember, this is first of all another important thing, sudden onset. Okay, he was fine earlier and all of a sudden he developed sudden onset of difficulty in breathing. On examination, the child has stridor. Now you know guys what is stridor? Stridor is an inspiratory effect which gives you a sign that there is an obstruction at the larynx. So it's an upper airway obstruction. And dyspnea. There is no associated fever. Which condition should be suspected and what would be the immediate management? Now guys, I have highlighted over here the green parts already. The green parts over here signify what are the important clues you get in this question. First of all, you need to see it was a short duration. Second thing, it was that there is a stridor, and stridor is an obstruction that also at the larynx. So upper airway obstruction. Third thing, there is no fever. Now what am I ruling out in this? See, if there is no fever, there is no sort of infection. So we are ruling out epiglottitis or croup. Laryngomalacia is a condition which is the most common anomaly in a newborn. And this child is already now 11 months old. So that way the duration is also ruled out. The thing which we have to think about here is foreign body obstruction, guys. Foreign body obstruction. Why? Sudden onset, stridor, upper respiratory tract obstruction. So think about foreign body obstruction. What is the management, guys? Now, if the child is more than 1 year, you have to see what type of obstruction it is. Either it is an upper airway obstruction or a lower airway. How do you get to know that? By the breath sounds. If you hear a stridor, it is an indication of an upper airway foreign body obstruction. If you hear any sort of wheezes, it is an indication of either it is in the bronchus or in the bronchioles. Now, if it is an upper airway obstruction, what is the maneuver, guys? It is the Heimlich maneuver. What do? Is you give an epigastric thrust over here and you press, and you have to press, which will be there, it's going to be backwards and upwards. Okay, apply pressure backwards and upwards. That is the Heimlich. Remember, it is only up for childs who are more than 1 year of age. Second thing is, what if it is in lower airway obstruction? Guys, in lower airway obstruction, Heimlich maneuver will not be working because it is based on pressure logic. That time now you have to do a bronchoscopy, and that is going to be your rigid bronchoscopy. What bronchoscopy it is going to be, guys? It is going to be rigid, not smooth, because smooth bronchoscopy will further, it will further push it inside lower and lower. All right, now the next thing we have to see is, what if there is an obstruction, a foreign body obstruction, but this time in a child who is less than 1 year? In that condition, guys, what you have to do, you have to give 5 back rubs, and then if it's not working, then you're going to ulta kar do bacche ko, and then facing the chest of the baby, you have to now give chest thrust. Okay, and that also in a declining position, and that is your method. How do you prevent, or sorry, how do you help a person who's suffering from obstruction? Remember, more than 1 year, upper airway Heimlich maneuver. More than 1 year, lower airway, you have to do rigid bronchoscopy. Less than 1 year, you have to get 5 back rubs and 5 chest thrust. Okay, next thing, guys, a 7-year-old male who is a known case of asthma, now presented with progressive difficulty in breathing and bilateral wheezes. A known case, sudden onset of severe difficulty in breathing. What is the diagnosis, guys? It is an acute exacerbation of asthma. Now, what happens in asthma is there is bronchoconstriction. Now, because of bronchoconstriction, the air will not be able to circulate through the body, so there will be hypoxia. So what is your management, guys? First of all is to correct the hypoxemia. Hypoxemia is oxygen, which is less oxygen in the blood, and second is to correct the airway obstruction, which is now bronchoconstricted. So for the oxygen, you're going to give O2 supplementation. For dilating the bronchus, you're going to give a short-acting beta agonist. That is going to be salbutamol. How are you going to give salbutamol, guys? You're going to give it via nebulization 3 times every 20 minutes. Now, even after this, even after the nebulization, still the child is complaining of difficulty of breathing. That time now you're going to give steroids. You're going to give IV hydrocortisone. Remember, guys, asthma is not something which happens all of a sudden. You should have reoccurrence. It will be having history of at least 3 or more. Then you will have the test also will be there, right? How to differentiate asthma from COPD, which is FEV1 will be more than 12% on the time of oxygen. That we will talk about in medicine. Okay. Now guys, another thing which I forgot to discuss in genetic disorders is, if a child comes with you with this specific history, okay, web neck, flat or shielded chest, increased space between the nipples, and cubitus valgus. Valgus means, remember I told valgus like gum, it is be knee, like knock knees, right? In this condition, now you have to suspect two syndromes. One is going to be Turner syndrome and one is going to be Noonan syndrome. If it is a female monosomy X, answer is Turner syndrome. If it is going to be 46XY, now in this condition, remember it is an autosomal, it is going to be a condition in which both males and females can get involved, and it is a dominant condition. Okay, remember the karyotype guys. In Turner syndrome, it is going to be 45XO, while in Noonan, it can be both male or female. IQ guys, remember in Turner syndrome it is going to be normal, a very important condition. Remember in Down syndrome it is going to be reduced. It is the most common genetic cause. What is the most common inherited cause of intellectual disability guys? Fragile X syndrome, correct? And along with this, now see in Noonan syndrome you will have the IQ is going to be low. Now the important part here in Turner's is you need to know there is streaked ovaries. Now because of streaked ovaries they are not functional, due to which there will be infertility and amenorrhea. While in case of Noonans, more commonly males are affected with Noonans, so you will have cryptorchidism. Now cryptorchidism will also because of cryptorchidism there is less testosterone production. Because of less testosterone production there will be delaying in puberty. Along with that, fertility also will be low. What are the associated anomalies? That is very important. Turner syndrome usually affects the left side of the heart, while as Noonan syndrome usually affects the right side of the heart. There are two anomalies which you have to remember in Turner syndrome. The most common type which you find is bicuspid aortic valve. Bicuspid aortic valve. While as the most specific, if they ask you, that is going to be co-attraction of the aorta. While in Noonan syndrome, the most common is going to be pulmonary stenosis. Okay. Another findings which you can see in Turner syndrome is short fourth metacarpal space, and along with that horseshoe kidney. What was horseshoe kidney at the end? No? They both are attached like this, the kidneys, right? So that is horseshoe kidney. Where do you find this guys? In Turner syndrome. Now guys, let's talk about the respiratory disorders. There are three sounds usually when you do auscultation you will hear. One is stridor. What does stridor means guys? First of all, it is an inspiratory issue. That also is going to be loud. Where? In the larynx. Second is wheeze. Wheeze is a musical one, heard during expiration. Where is the issue? Either the bronchus or the bronchioles. Then crepitations. What are crepitations? Basically bubbling, crackles which we say. Where is the issue? It is going to be in the alveolus. Either there is an alveolar block or there is pulmonary edema. With this information, let's go with another question. A 6-month-old baby with a history of upper respiratory tract infection 1 week ago now presents with increase in breathing difficulty for the past 2 days. Means there is now an exacerbation. There is no previous similar history. If there is no previous similar history, we are ruling out asthma. On examination, baby has low-grade fever and bilateral wheeze. Now with bilateral wheeze, what we are finding, first of all, there is an expiratory issue. Second, kya hai? It is the area of involvement is bronchus or the bronchiole. Chest X-ray reveals bilateral hyperinflation. Guys, whenever this thing comes, okay, wheezes, history of wheeze, history first upper respiratory tract infection tha, then after that lower respiratory tract infection ho gaya, patient has wheeze, and more importantly on X-ray you are having bilateral hyperinflation. Guys, the diagnosis is going to be acute bronchiolitis. The diagnosis is going to be acute bronchiolitis. The most common cause of acute bronchiolitis is respiratory syncytial virus. It occurs usually in a child who is less than 2 years, especially in the winter season. What do you get in the X-ray guys? Bilateral hyperinflation. What is the management guys? If it is normal, a normal child who is suffering for acute bronchiolitis, you are going to give for fever antipyretics. Difficulty in breathing, you'll give O2 inhalation and salbutamol for bronchodilation. If a patient is immunodeficient, example an HIV infected patient, or who has congenital heart disease, or if someone has any other immunodeficiency, that time you have to give an antiviral that is known as guys ribavirin. That is known as ribavirin. Okay. Now guys, let's talk about pneumonia in children. Okay. Now pneumonia and diarrhea are the most common cause of under 5 mortality rate in children. We are going to follow which guidelines guys? It is known as IMNCI guidelines, which is Integrated Management of Neonatal and Childhood Illness. Integrated Management of Neonatal Childhood Illness. They are dividing it into 3 categories guys. When there is no pneumonia, remember it is going to be green in color. When there is pneumonia, it is going to be yellow in color. While if there is severe pneumonia, there is no such thing as very, very severe. Severe is severe. Either it is, even if in the question very severe, you have to treat it as severe. It is going to be in pink and not red. Remember, there will be an option so like this. So severe pneumonia comes in, option will be red, pink. You have to mark pink. Okay, remember this image that time if the question comes like that. Now, what they're going to ask you is, what are the terminologies? What are the features and what is the management? Guys, when no pneumonia is there, the baby will have fever, cough and cold, but no other signs of chest indrawing, no other signs of hypoxia, nothing severe. So that for that condition, what you have to do, just give paracetamol and send the patient home. No issues. Now in pneumonia, the patient will have fever, cough, cold, coryza is there. Along with that, fast breathing will be there. Fast breathing will be there. Along with that, you will see chest indrawing. Signs of difficulty in breathing. So now we know this is pneumonia. For pneumonia type patient, now over here what we are going to do is, you're also going to send the patient home only, but along with this, now you're going to give an antibiotic that is going to be amoxicillin for 5 days. Now in severe pneumonia, what happens is, all the features you will add. Along with this, you're going to have hypoxia. In the other two conditions, hypoxia was not there. In pneumonia, what was there? Fast breathing and chest indrawing. But in severe pneumonia, you're going to have hypoxia and any of the 4 danger signs. Guys, what are the danger signs? The baby will be lethargic. The baby will not eat or drink. The baby will have convulsions, which is seizures, and the baby might also have cyanosis. These are all the features of danger signs. Now, what is the management of severe pneumonia? Guys, now you cannot treat it in a primary healthcare. You are going to give the first antibiotic dose, which is going to be ampicillin and gentamicin for gram-positive and gram-negative coverage, and send the patient to a higher center. Okay. Now, what is fast breathing, guys? This is another question. If a child, a baby, is less than 2 months, for him more than 60. From 2 months to 1 year, it is going to be more than 50. It's going to be fast breathing. Anything in above 1 year, he is going to have more than 40 respiratory rate. That is going to be fast breathing for him. Remember, less than 2, 60. 2 to 1 year is going to be 50, and more than 1 year is going to be 40. Let us talk about the most common etiologies in pneumonia. The most common overall is strep pneumonia, and also known as, guys, I asked you to answer it last time. Strep pneumonia is also known as pneumococcus. Okay, the most common virus, if they'll ask you, it is going to be respiratory syncytial virus. If it is an adolescent child, which is 10 to 19 years of age, or an atypical pneumonia like picture, the most common organism is going to be Mycoplasma pneumonia. And if it is an HIV infected, a very favorite question, what is the diagnosis? What is the organism, guys? Pneumocystic jirovecii. Okay. Next, guys, if you will have this picture, guys, so see, you know that in how, first of all, directly you can see there is some abnormality. Why? Because in both the lung fields, there should be only air, right? And then air is black in color. But over here, you can see in the right sided upper lobe, you're basically having some consolidation of like white opacities are there. So this is a lobar consolidation, guys. If they'll ask you what is the most common cause of lobar consolidation, which organism, again it is going to be strep pneumonia. Okay, it is going to be strep pneumonia, or also known as pneumococcus. What is your management, guys? 3rd generation cephalosporins. Another condition over here where you can see multiple circles will be there, okay, like cavities, air filled cavities will be there. Okay, so a lining of white, but inside air will be there. These are pneumatoceles, guys, patchy consolidations. The most common cause of pneumatoceles is Staphylococcus aureus, guys, but this is no ordinary Staphylococcus aureus. This is methicillin resistant Staphylococcus aureus. And guys, what is the drug of choice of methicillin resistant Staphylococcus aureus? Guys, it is vancomycin. What it is, guys? It is vancomycin. Okay. Now we are done with respiratory. Now let's talk about an important topic, that is going to be cardiovascular disorders. Guys, in cardiovascular disorders, first let's talk about the normal thing. So you need to know there is placental connection, obviously, and along with the placenta, you'll have additional communications. What are the additional communications involved over here? It is going to be the umbilical vessels. It is going to be the ductus arteriosus. It is going to be the ductus venosus, and it is going to be the foramen ovale. How does it work, guys? See, if you see, first from the placenta, oxygenated blood goes to the umbilical artery or vein, guys. It is going to be umbilical vein. Remember, umbilical vein carries oxygenated blood, whereas umbilical artery carries deoxygenated blood. Then it bypasses the liver via ductus venosus. From the ductus venosus, it goes to the foramen ovale. From the foramen ovale, it goes to the ductus arteriosus, and then rest of the body. Correct? Let us now talk about what are the closures. Now see, in the question they can ask you two type of closure. What is anatomical closure ka order and what is functional closure ka order. Okay, remember functional closure is going to be same, guys. First your umbilical vessels are going to get closed, first, second, third and fourth. Okay, then after, just remember the order, guys. Then it's going to be ductus venosus, then will be your foramen ovale, and last will be your ductus arteriosus. This is, guys, functional closure. But now on the other hand, if they're going to ask you what is the anatomical closure ka order, in anatomical order the first two are same. What is going to be there? First is going to be your umbilical vessels, then will be your ductus venosus. Now the change is going to be there in the last two. It's going to be interchange. Remember, guys, in anatomical closure you're going to have first is going to be ductus arteriosus, then the last one to close is going to be your foramen ovale by 3 months of age. What did I say, guys? In the differentiation of the closure of these all things, remember there is functional and anatomical. In functional, the order is going to be same. Umbilical vessels, ductus venosus, then foramen ovale, and then patent ductus arteriosus. But in anatomical closure, remember foramen ovale is the last one to get closed. Okay, please remember this. They will ask you this question. Okay, functional ka difference kya hai aur anatomical difference kya hai. Then, guys, now let us talk about this question, this slide, which is going to be very, very important. I'm telling you, at least pakka 2 questions or 1 question is going to come from here. Let's talk about what are the specific heart defects you see in cases of genetic disorders or any maternal infection or condition. First of all, in Down syndrome, what is the side? We already talked about this, guys. It is endocardial Cushing defect. So you will have ASD plus VSD both, है ना? So atrioventricular septal defect is there. Okay, so ASD plus septal defect will be there. That is going to be your endocardial Cushing defect. Better way to say this is atrioventricular septal defect. Okay. Now in trisomy 18, guys, is Edwards. Trisomy 13 is Patau. In both of them, the most common cardiac condition you see abnormality is going to be ventricular septal defect. Turner's, just now we talked about, guys, most common is bicuspid aortic valve, whereas most specific if they ask is co-attraction of the aorta. In Noonan syndrome, the most common is going to be pulmonic stenosis. What about in DiGeorge, guys? Catch-22. Tetralogy of Fallot. While if you talk about maternal infections such as rubella, the most common if you see defect is patent ductus arteriosus. If you have a tetratogen like lithium, what is the most common anomaly you see? That is Epstein's anomaly. What about, guys, if the mother has a history of alcohol consumption and phenytoin? Again, ventricular septal defect. If you have an infant of diabetic mother, that also overt. I told you earlier also, gestational diabetes does not cause any anomaly to the child, but overt diabetes, which means the mother was already diabetic before pregnancy, there are some anomalies. The most common is going to be ventricular septal defect. But if they ask you which is the most specific, that is going to be your transposition of the great arteries. TGA, transposition of the great arteries. Okay. In SLE, guys, there are two, the defect which will be there is going to be your fetal heart block. And the antibodies which you'll see is, you'll see anti-Rho and anti-La. That is also called as, guys, SSA or SSB. So, guys, this is a very important table, simple table, but you should not mistake this. You should not have any mistakes with this. What you guys have to do is take a sticky note, mark this all and keep it in front of your study table. So whenever, you just like in the day, you just keep a glance and then, it keeps on retaining and you revise this and you don't forget this again. Okay. Now let's talk about some of them in detail. Let's talk about Epstein anomalies, guys. In Epstein anomaly, what was that? Lithium exposure. So now what is happening is when lithium exposure is there, there is the downward deviation of the tricuspid valve. That is going to be tricuspid valve, because of which, guys, now the size of the right atrium is going to increase. Now because the right atrium is covering the part of the right ventricle, we call this as atrialization of the right ventricle. Okay, due to which over here you can see the heart is now like a box. So that's why what you'll have a box shaped heart. That is all about, guys, Epstein anomaly. Now guys, let's talk about the classification of congenital heart disease. It is divided into two types, acyanotic and cyanotic heart disease. Acyanotic means there is no signs of cyanosis, which means there is no sign of hypoxia. Whereas cyanotic, there is sign of hypoxia, there is lack of oxygen. Now why acyanotic heart diseases are called as acyanotic? There is a logic. See, all the disorders which come under acyanotic heart disease have left to right shunting. What do you mean by left to right shunting, guys? Is you know that the left side of the heart contains oxygenated blood, and the left side of the heart is the one which pumps maximum and there is too much pressure. So that is why oxygenated blood, now what happens in acyanotic heart diseases, the blood is going to flow from the left side of the heart to the right side of the heart, either from the atria, that is going to be an atrial septal defect, either through the ventricular septal, so that is known as ventricular septal defect, or from the lower part, that is going to be patent ductus arteriosus. So oxygenated blood is going to go from the left side to the right side, but eventually throughout the body. So that's why at least oxygen is coming now. So that is why this is known as acyanotic heart disease. What are the acyanotic heart diseases, guys? One is going to be atrial septal defect, other one is going to be ventricular septal defect, patent ductus arteriosus, and a one which people do confuse, that is co-attraction of the aorta. Let's talk about now cyanotic heart disease. How do you remember which are all the cyanotic heart disease? All the diseases which starts with T are cyanotic heart diseases. Tetralogy of Fallot, transposition of the great arteries, tricuspid atresia, and total anomalous pulmonary venous connection. Okay, all the ones which start with T are cyanotic heart diseases. Hypoxia isme hota hai. Okay, now let's talk about some of the details in this. What are the things you find out? Now guys, in ventricular septal defect, you are going to have a pansystolic murmur. What is pansystolic murmur? Continuously between S1, zoop, zoop, zoop. Like this will be the continuous of pansystolic murmur. Where do you find this, guys? You find this at the left fourth intercostal space, parasternal. Okay, shunt murmur. Guys, in ASD, you don't have any shunt murmur. Why? In VSD, we are having shunt murmur, we are having pansystolic murmur because of increase in turbulent flow. While in ASD, the pressure is not that much, that's why there is no turbulence. In ASD, the specific feature which you have is wide, fixed, S2 split. क्या है? Wide, fixed, S2 split. ठीक है? Guys, in patent ductus arteriosus, it is outside. So because it is outside, you will have a continuous, also known as machinery murmur. Okay. Along with this, what you have to know in PDA is there are two conditions. If you have person is diagnosed with Pedia but it is preterm, you can give them prostaglandin inhibitors, that is NSAIDs like indomethacin, but ibuprofen is much more better than indomethacin. You will give NSAIDs. These both are क्या है, guys? These are NSAIDs. ठीक है? While if it is a term child, that time now only thing what you have to do is surgery. Okay, now let's talk about, guys, co-attraction of the aorta. Co-attraction of the aorta basically means narrowing. Now is this narrowing complete or incomplete? A PYQ, this is incomplete narrowing. What is the location, guys? Juxtaductal, just close to the ductus arteriosus. Okay, now guys, what happens is, just imagine if this is your blood vessel which is going to the upper part, and this is the blood vessel which is going to the lower part of your body. Here there is some narrowing. Okay, now there is narrowing over here, and the lower part of the body will receive less oxygen. So that is why the first feature you will have is claudication pain. Okay, you will have pain, claudication pain. Second thing is, what is claudication pain, guys? After walking a little, you'll have you'll start your foot and all your limbs, lower limbs will start hurting, right? Second condition is, now because the blood supply is very less, you will have feeble femoral pulse. Correct? Now along with this, you guys know that the blood supply to the lower part of the body is less. You know that the kidney is also in the lower part. This is receiving decrease in blood flow. So this activates the renin-angiotensin mechanism, RAS mechanism, due to which now there will be hypertension. Okay. Now guys, our body is very majestic, alright? So now because there is already narrowing over here, our body starts developing new circulation that is known as collaterals. And where is the location of these collaterals, guys? It is going to be in the inferior part of the rib, inferior ribs. Now because of this collaterals, there will be some notching around the rib, and that is a specific finding co-attraction of the aorta. You will have inferior nib notching. That is shown over here, guys. Okay, so over here, remember it is inferior, not superior rib notching. Okay, superior rib notching is usually seen in neuromuscular disorders. All right, so this is all about your co-attraction of aorta. Let's talk about, guys, now cyanotic heart disease. In cyanotic heart disease, the most common type is going to be tetralogy of Fallot. TOF, tetralogy of Fallot. Now there are 4 components of tetralogy of Fallot. Remember it in this order. First of all, you see over here, your aorta is going to be overriding. It is going to come around the right side, so that is known as overriding of the aorta. Then along with this, there is increase in pressure in the right side of right ventricle, due to which they will be having right ventricular hypertrophy. Now because of this, there will be narrowing around the pulmonic valve, that will be subpulmonic stenosis. Okay, subpulmonic stenosis also will be can be mentioned as infundibular hypertrophy or right ventricular outflow tract obstruction, RVOT. And then the last one is going to be, you're going to have a septal defect, that is going to be ventricular septal defect. Overriding of the aorta, right ventricular hypertrophy, subpulmonic stenosis, also known as RVOT, also known as infundibular hypertrophy, and ventricular septal defect. If they ask you, guys, the most important determinant of cyanosis in tetralogy of Fallot is going to be right ventricular outflow tract obstruction. Okay, that is going to be your answer. Now guys, let's talk about some important characteristic features. If you have a boot-shaped heart, what is the diagnosis, guys? Tetralogy of Fallot. What is the cause? Right ventricular hypertrophy. If you have something known as egg on string appearance, that is going to be the diagnosis is going to be transposition of the great arteries. Why this happens is, in front of the heart now there will be an aorta, and then will be your the pulmonic trunk. So that's why it looks like an egg on string appearance. Okay, aorta in front, and then the pulmonary trunk. Okay, then guys, if you have a snowman like appearance or a figure of 8 like appearance, snowman, yeah, figure of 8 appearance, now the diagnosis is going to be, guys, total anomalous pulmonary venous connection. That also what type, guys? Supracardiac. Okay, what type, guys? Supracardiac. So these are the important things which I wanted you guys to know in case of congenital heart disease. Now let's talk about something related to some vasculitis. The most common vasculitis in childhood is known as Kawasaki disease. What is the issue? And remember what type of Kawasaki, what type of vasculitis this is? This is medium vessel vasculitis. Okay. What is the issue is because of the inflammation of the vessels of the coronary artery, there will be myocardial ischemia and there will also be coronary aneurysm. Now there are 3 stages in case of Kawasaki. Acute stage, which is around 1 to 2 weeks. Subacute state, which is around 3 to 4 weeks. And convalescent, which means recovery, that is around 6 to 8 weeks. If they'll ask you what is the most dangerous phase, subacute is the most dangerous phase. So what we want to do is we want to bypass this subacute stage and directly go to the recovery stage. Okay. Let's talk about the features seen in Kawasaki. You can remember that with the mnemonic of cream. First of all, you'll have fever. Any fever more than 5 days. Plus the features of cream. C stands for conjunctivitis. And that also what type of conjunctivitis, guys? Bilateral non-purulent conjunctivitis. It should be non-purulent. R stands for rash. What type of rash you guys will get? Maculopapular rash. E will stand for edema. Where will you see edema, guys? In the extremities. A stands for adenopathy. What type of adenopathy, guys? Cervical lymphadenopathy. Lymphadenopathy. And over here, M stands for mucosal lesion. And what is the mucosal lesion, guys, you see in Kawasaki? That is going to be strawberry tongue. Okay. Now they'll ask you, how do you diagnose this condition, guys? Diagnosis requires fever more than 5 days plus any of the 4 out of 5 which I just mentioned. Cream features, conjunctivitis, rash, edema, strawberry tongue will be there, and cervical lymphadenopathy. Okay. If they'll ask you what is the treatment, guys, you have to give intravenous immunoglobulins. Okay, and along with that aspirin. Okay. So guys, this is it for part 6. I hope you guys are always reading this before you're done. I hope after you're done with this topic. This is all about, I want you guys to know about respiratory, pediatric emergencies, cardiovascular, and something about vasculitis. See you guys for the last video, part 7. Bye bye.